Hi, I just want to say thank you. It's so nice to be here tonight, and I'm glad I get to share with you guys a little bit about dialectical behavior therapy and how it might fit into treatment for bipolar disorder. It's come quite a long way since its original inceptions and its original targeted population, and so we'll talk a little bit more about that as the evening progresses. The keyboard.
It slides out.
It's like,
Yeah.
Okay. So this is a brief overview of what we'll be talking about tonight. First, just do an overview of the comparison between borderline personality disorder and bipolar disorder, as DBT was originally developed to treat borderline personality disorder. Do an introduction to DBT and talk about how DBT strategies may be especially helpful for family members of people with some kind of mood dysregulation disorder. And we'll end the wrap-up and any questions that you have. Okay, so dialectical behavior therapy is a form of cognitive behavior therapy. Where it differs a little bit from straight cognitive behavioral therapy is that it integrates mindfulness practices that came a little bit from Eastern Buddhist philosophies. Marshall Linehan up at the University of Washington developed DBT. And the first manual was published back in the late 80s, early 90s. So it has this core of CBT therapy to it, but does integrate what we call dialectics, which is two things that are seemingly opposed can be held true at the same time. So things that seem to be opposite can go together. And so one of the core dialectics that we work with in dialectical behavior therapy is the dialectic of acceptance and change. So accepting your emotion, accepting yourself, accepting the present moment as it is, but also working to change problematic triggers and patterns and behaviors that might lead to a reduced quality of life for that person. So it balances out those two concepts. So it was initially developed to treat borderline personality disorder, and it's been really expanded and adapted to now treat a lot of different problems associated with emotion dysregulation. There are variations used for treating substance use disorders, for eating disorders. UCSD's program, they integrate a lot of DBT skills into their eating disorder program, and now being really expanded to treat a lot of problems associated with emotion dysregulation. So bipolar disorder, anxiety disorders. I know they're starting to run randomized research trials looking at dialectical behavior therapy with bipolar disorder. Okay, so this is a little chart that shows some of the differences between bipolar disorder and borderline personality disorder. So as where bipolar disorder really goes back and forth between these periods of very elevated mood, mania, and very low mood depression. You can see bipolar disorder is much shorter bursts, so much smaller length of time between highs and lows, and borderline personality disorder does not typically experience periods of mania, so that is one major way that it is distinguished from bipolar disorder. So more so periods of very rapid change to low mood states and back up to more of baseline, so rapid. It is a little bit different from rapid cycling, but we don't make that much of a distinction between the ultra-rapid cycling version of bipolar disorder and BPD. There's no real support for making that kind of distinction in the literature. So the major differences are really that bipolar disorder is associated with much longer periods in these different mood states and much longer length of time between these mood episodes, whereas borderline personality disorder is quite frequently going up and down in a period of a day. So this is DSM4 criteria for the diagnoses. So the core problems of BPD are similar to bipolar disorder in that it's conceptualized as a disorder of emotion dysregulation. So you can look at some of these criteria: emotional instability and reactivity. So that's a very central piece to borderline personality disorder. And then you can look at these other symptoms, and we basically group them into cognitive dysregulation and behavioral dysregulation. And it's kind of conceptualized as the cognitive dysregulation and behavior dysregulation symptoms being consequences of the emotion dysregulation. So at the core of BPD, we have this dysregulated emotional state with lots of ups and downs and extreme mood states frequently happening and quickly happening. And then because of that, a lot of issues with thinking clearly, with being able to process what's happening, and then in turn behaving impulsively. And so you can definitely draw some similarities to bipolar disorder from that type of thing, whereas behavioral inhibition and behavior dysregulation and problematic behaviors are occurring simultaneously with emotion dysregulation. So these are some of the main overlaps of BPD with bipolar disorder. So the mood shifts, the erratic or engaging in high-risk behaviors, emotional sensitivity, interpersonal conflict. Both are seen as biologically based disorders that are really affected by your social interactions and your relationships with others, how others treat you and how you treat them on a daily basis. Some of the biggest differences are that BPD has much more anger and aggression and non-suicidal self-injury associated with that. So things like cutting and burning intentionally without the person wanting to die or to lethally harm themselves. That's much more associated with borderline personality disorder than it is with bipolar disorder. And then, of course, bipolar disorder are more likely to have those extended periods of extreme euphoric mood, whereas that's not so much present in borderline personality disorder. And I think another thing just to mention in this line is that medications for borderline personality disorder and bipolar disorder tend to be very similar. So anticonvulsants and antipsychotics tend to be the most effective for both of those groups. So that's another similarity that they hold. So there's some overlap in the diagnoses. About 10 to, these are findings from research, about 10 to 20% of our patients with borderline personality disorder also meet criteria for bipolar disorder. So you may run into people that experience both, where on a day-to-day basis between periods of mania or periods of severe depression, they may have those extreme ups and downs, and then on top of that have to deal with these episodes of high elevated mood or very, very low depression that stay around. And so that's something to keep in mind. And in turn of that, 25% of patients with bipolar disorder also meet criteria for borderline personality disorder. So there is quite a bit of overlap, and this is kind of moving along with conceptualization of these things being on a continuum of emotion dysregulation rather than always completely separate categories and completely separate unrelated things. So it is very common for patients to receive incorrect diagnoses because there is these similar characteristics and overlap between these two disorders. So we really recommend that when people are first seeking out treatment and trying to figure out what's going on with them and getting a diagnosis, that they do see someone who does a structured assessment. It's used, most of the problems with diagnosis come from the use of unreliable procedures, and so using some kind of structured assessment and structured interview is a good way to get a clear and accurate diagnosis off the bat. And eventually, this is another interesting thing, about half the patients who initially get a label of bipolar disorder will eventually then be better categorized as BPD. And so that's another thing to look out for, that if your current course of treatment for bipolar disorder is not effective for whatever reason, or you feel like that doesn't completely explain all of what might be happening with you or with a loved one, that might be another explanation, that it could be a comorbid diagnosis or a better explanation of what that person's mood state is on a day-to-day basis. So now we'll get a little bit to the nitty-gritty of DBT. So the basic structure of DBT is individual therapy. These are weekly sessions, usually 60 minutes. Some people do 90 minutes. A DBT skills group. Skills groups are groups of 5 to 10 clients typically. It's taught in a more didactic and classroom format, so opposed to being a process group where people come and talk a lot about their own personal experiences or their own things that they're struggling with. It's more of like a teaching format and a way to deliver the teaching of skills to a number of clients at the same time so that they can get that information and then take that back to their individual therapist and apply it to their individual therapy. And so that's how a skills group might be different from process therapy groups. And it's a 6-month commitment. It lasts 6 months to go through all the modules, and we'll talk about what those are. So it is a pretty lengthy commitment for people to make, but it does ensure that people are learning. The way most DBT clinics run groups is that they do a homework check-in. Homework is assigned each week on whatever skill is taught for that night. So the first order of business is to do mindfulness, do a homework check-in, teach the skill for that evening, and then do a wind down. And so that's the kind of structure that you can expect from a DBT skills group. Phone coaching is another really important piece. Phone coaching is meant to help people generalize their skills that they learn in group and what they learn in working on in individual therapy to their lives. So this means that DBT therapists are typically available to their clients outside of session by phone to help them solve problems as they occur in their environment. And so that's a really important piece because it's one thing to talk about how you're going to handle something in your 1 hour a week at the office and talk about how you might do something in group, but it's a whole other thing to actually be faced in that situation when you might be feeling very depressed or might be feeling very dysregulated. How am I going to handle solving a problem or getting through this in an effective way? So that's why phone coaching is there, to help generalize those skills. Another really important key piece is the DBT consultation team. So DBT therapists, if you're practicing adherent DBT the way it was studied at University of Washington and by other clinics and shown to be effective, utilizes a consultation team where all of the therapists meet and once a week and review cases, get help on cases that they feel stuck with or where the client isn't progressing in the way that you would like. And get support from other team members. And so this is a really important key piece because it ensures that there is some peer review, usually, of how you're handling your client load, but also support for the therapist and reduces burnout so that they can continue to be effective. Because you can imagine with being available for phone coaching outside of session, there's definitely a potential for that. And so it really is meant to help the therapist be most effective, prevent that burnout, and also make sure that the client is getting services that are meeting their needs as well. There has also been some modifications to this basic structure for adolescents. There are now adolescent DBT programs, and a couple of the modifications include a multifamily skills group where the adolescent attends the group along with at least one of their parents. And so both the parent and the child are learning the DBT skills, doing the homework assignments, learning the mindfulness, and so they're both getting that piece. We also require mandatory parent training or family therapy to accompany that, because such a big piece of helping any teenager is helping their parents and interact with them effectively. And so that's a really big piece, and parents need support too. Typically they wouldn't be coming to therapy if they felt like they were doing the best job that they could and that everything was going well. They need the support and they need those skills too. And so that's another really important piece of that. I know at least in our clinic, we really also emphasize family therapy for a lot of our adult clients as well, just because typically their family members are very involved in their care and in their treatment, and so we really enjoy having them come and participate in those sessions as well. Okay, so these are some of the main strategies from DBT. There's a big focus on regulating emotion, and so the skills address both ways to handle intense emotions in the short term when they're occurring, but also things that you can do to prevent emotion dysregulation in the long run. So that's another way that it's kind of balanced with those dialectics between short term and long term. So we work with mainly cognitive behavioral strategies and using mindfulness to reduce triggers, to reduce the occurrence of triggers and the frequency of triggers. So especially if there's problematic social or interpersonal interactions, that is a major trigger in bipolar disorder for dysregulated states, then we want to address those and reduce those. Reducing reactivity and sensitivity to those triggers, so you can actually really help people build up resistance and tolerance to the things that do trigger them. And so that is another strategy, so that even if that happens, the person can cope with it a lot better and get through it without doing anything to make the situation worse. To reduce intensity of emotion episodes, so that when these things happen, they're shorter in occurrence and less severe. There's a lot of focus on distraction early on, which is focusing on how to get through something without making the situation worse. It's a short-term strategy, and so eventually we want to integrate that with those longer-term strategies to prevent mood dysregulation. And then we also want to increase tolerance to emotions. So this is a lot more relevant usually to borderline personality disorder, but there are big patterns of avoidance that keep that person dysregulated because they feel like they can't tolerate their emotion. They do a lot of things to try to avoid or not experience their emotion, and in turn that leads to the future more dysregulated states. And so we use mindfulness and approaching instead of avoiding as ways to increase tolerance to those emotional states. It does really apply especially to depressed states and bipolar disorder, where there might be a real difficulty tolerating that, especially when the person has been experiencing a period of mania or euphoria. It might be a very, very difficult thing to then tolerate a very low mood state, and so that might be a strategy that might be especially useful when there's a big jump like that. And then our big focus in DBT is, despite the emotions that are happening, how can you get through that situation being effective? And when we say effective, we mean how do we get this person to live according to their values and toward their goals for their life, and how to create a meaningful life despite these emotions that might come up and give them trouble. So that's always our ultimate goal, is a focus on behavior. So this is a big scary model that looks complicated, but I promise I'll break it down for you guys. So this just explains those different strategies that we're talking about. So we conceptualize emotion dysregulation happening as a process of there being some kind of cue or trigger. And those triggers can be internal triggers, so they can be naturally changes and fluxes in biology that might cause a change in emotion, so they can be something internal, or they can be something external, like a family member being critical, or an argument with a loved one. That might be an external cue and an external trigger. And then that in turn will cause a dysregulated emotional state. And then when we found that when people do things to avoid those states by engaging in problematic behaviors, a lot of that might be avoidance. You can think about when a person's really depressed, how if they're feeling depressed, they avoid the world by staying inside and isolating and staying away from people, having a difficult time getting out of bed. And while that provides some temporary relief from what they might be feeling if they got out and put themselves out there, it in turn actually reinforces that reaction to the trigger. And so when that same trigger happens again, they're more likely to feel that way and more likely to get stuck. So the more that people act in ways that are consistent with their emotions, the more likely they're going to have that same emotion in response to that situation, and they're more likely they're going to act that way in the future. So if people are getting very, very stuck in depression, it's a very useful strategy to actually act opposite to how you're feeling and get out and do things, and we call that behavioral activation. But to get out of bed, to hang out with your friends, all of that in order to stop the cycle and help them come out of that state a lot sooner. these are the main skills that are taught in the group. And so the first module, the core of dialectical behavior therapy, is mindfulness module, where we teach people to become more aware of what's happening in the present moment, what's happening with their emotions, what's happening with their thoughts, what they feel like doing behaviorally. And the reason for that is not only to develop self-awareness that might be useful in understanding their responses to triggers or understanding why they might do the things that they do, but also because it helps develop tolerance to uncomfortable emotional states that they might try to escape otherwise. And so it serves a couple purposes. Distress tolerance, which focuses on getting people through crises. And this basically hinges on the, once you're already in a dysregulated state, what can you do to get through it without engaging in a problem behavior? So something like attempting suicide, or something like getting into an argument or doing something impulsively. That's where distress tolerance is focused. When you're already kind of in a crisis, how can you get through it without acting on those types of urges to do those behaviors? Emotion regulation is kind of the long-term strategies. It focuses on what you can do in the long term to regulate your emotion. So there's a big piece of it that focuses on sleep hygiene, so regulating sleep, going to bed at the same time every night, getting up at the same time every morning, getting the same number of hours of sleep, nutrition, exercise routine. Those types of things are very, very important in actually reducing the frequency of manic episodes in bipolar disorder. And so we really go over that as daily things to do to prevent the frequency and intensity of those episodes when they are to occur. Other pieces to that might be building up positive experiences, doing things that may be hard in the short term but will give that person a sense of mastery and accomplishment in the long term. And those types of things are very effective for helping get people out of depression and get them to function well even when they're in depressive episodes. And so that's a very, very important piece to that as well. And then lastly, interpersonal effectiveness. And interpersonal effectiveness focuses a lot on how do you get what you want from people. So how to pose requests in ways where you're likely to do that effectively, but also how can you improve your relationships with people around you. What are ways of communicating that are likely, even when you're in a conflict or in an argument, likely to still respect yourself and still respect and have a relationship with that other person, even when you're in periods of disagreement and arguing. And so that's a really, really important piece, especially given that interpersonal relationships are so important as possible sources of triggers in bipolar disorder. So this is kind of piggybacking on that exact statement. So relapse rate for mood episodes 9 months after a hospitalization for those with bipolar disorder, 94% in families that have what they would call critical and intrusive attitudes or behaviors. So those are things like hostile or critical way of speaking with each other, whereas there are only 17% in families that don't have that style of communicating and don't have a lot of conflict. So you can see that that makes a huge difference on whether or not that person with bipolar disorder is going to end up back in the hospital or how their family is communicating to them. So it's a really, really important piece, and it actually predicts relapse much more than medication compliance. So whereas medications are a really, really important piece of it, family interaction and social interaction and relationships are just as important to helping the person function well during different periods of mania or depression. And this is a very similar pattern to what we see in borderline personality disorder as well. So I know with our clinic, like I said, even with our adults, we've put a lot of emphasis on family relationships and including family members in treatment for this very reason, because with both bipolar disorder and borderline personality disorder, those family relationships are so important to the person's functioning that we focus a lot on enhancing those and helping them engage in effective problem solving rather than arguing and conflict. And so these are some more outcomes from the research on adding family therapy to medications, and so you can see again, when you add that family component into treatment, it's much more effective in helping that person. So these are some of the ways that we aim to help family members who come to our clinic asking for help with loved ones. We do family consultations even when the primary identified patient isn't choosing to be involved with treatment at the clinic or with anyone. We will give family consultations, so that's another option for people a lot of times. But we focus on discouraging what we call ineffective behaviors, so behaviors that have a lot of negative consequences for the person, even if they solve problems in the short term for them, and ultimately are keeping them stuck or not helping them move toward larger goals for themselves. And so we discourage those behaviors by teaching family members to listen very carefully and asking questions, talking about things of just factual basis, so rather than jumping to interpretations and assumptions. An example of that would be, I can tell when you said that you meant this, or I can tell that when you did this you were trying to do this. Those would be examples of jumping to interpretations or analyzing the motivations of the other person. So instead of that, we stick with just explaining the facts. So when you did this, I felt, I thought, I wanted, those types of things in order to help those interactions go more smoothly. We focus on those I statements, so just like you learn in elementary school, kind of talk about I feel, I think, I want, I need. We go back to those basics and talk about your own reactions and needs and responses to the other person, rather than focusing on their behavior or how the things that they're doing may be making you feel. So instead, taking ownership of those feelings. We also really emphasize this gentle manner, so instead of that critical and hostile tone, which might be associated with higher rates of relapse in bipolar disorder, we really emphasize talking to the person gently. So even in periods where you might be very upset with the person or very angry with things that they've done or very scared, how to still talk to them in a gentle way that isn't as critical or as hostile. And we talk about validating instead of judging, and I'll go over validating a little bit more. We focus on describing the downside of the behavior. So there's this big misnomer that lectures are very effective ways to get people to change. And actually we call that the lecture fallacy, that usually lecturing people and telling them about all the reasons they should or shouldn't do something aren't very effective at actually getting them to do what you want them to do or not doing what you don't want them to do. So instead, we want to just focus on what are the major consequences of their behaviors that matter to them, highlighting those briefly, and focusing on integrating that with validation and understanding in a gentle manner. And then lastly, we focus on behavioral principles of reinforcing and punishing. So instead of reinforcing ineffective behaviors, focus on leaving or preventing reinforcement of those behaviors. You might see this a lot of times if someone is saying that they feel very depressed and they can't get up. They might have a lot of friends or family that come into the room and try to get them going and out of bed and telling them how wonderful they are and how great their life is. And that might be something, if that's something they really care about, is getting that kind of love and support from their family members and they don't know how to ask for that otherwise, that might become a way of communicating that through saying that they're depressed or through actually feeling depressed. That might be a way for them to get those needs met. And so instead, we focus on how can you instead reinforce and use that love and use that affection in the times that they're getting through those episodes in a really functional and effective way instead of when they might not be. So we focus on the flip side, encouraging effective behaviors. So noticing and reacting positively, even if it's small, to changes that the person is making. So if someone is very reluctant to take medications at first and then they start at least taking them some of the time, that's definitely a step forward from what they were doing. And so noticing that and giving a lot of praise and positive attention for that is very important. even if it's not completely what you want the person to be doing. So even small steps, it's important to praise. Being responsive and taking the person seriously. So when they're coming to you and asking for support, using these strategies of acknowledging their struggle, acknowledging how things might be hard, compromising and trying to find the middle ground when you have one idea about how they should be doing or what they should be doing and they have another. And always balancing out demands and requests with attention and love. And so that's another important things. So we also really emphasize on doing these things before problem behaviors occur, before problems are occurring. So this is a little bit more about this concept of validation. So validation is basically communicating to the other person that what they're doing makes sense, and that might sometimes be very, very difficult for family members to understand, especially if the person's behavior is very disorganized, or if their thinking and speech appears very disorganized. It might be very difficult to understand why that might be happening. And so we focus on really helping build empathy and compassion, but also communicating to that person that even if you don't agree with what they've done or how they're handling things, that you can at least understand why it is that way. So as we go through these different pieces of validation, I'll talk more about that. But essentially the goal is to decrease invalidation within a family and within loved ones. So, and increase validation. So increase the understanding, the compassion, and the empathy, and decrease the judgment and the communicating that they don't make sense, or that what they're doing doesn't make any sense. So we want to decrease that. So the place to start is describing how behaviors and emotions do make sense. And so there's a couple ways that this might be applicable. Given their past experiences in biology, it might make sense about why a person's doing what they're doing. At times, individuals, especially in manic states who have bipolar disorder, do very, very odd, bizarre, and disorganized impulsive behaviors that may seem very odd to the people standing outside and just observing that. But you can see how that makes sense given the person's biology and what they're experiencing at the time. So even if what they're doing appears very odd and bizarre, trying to make sense of it by, okay, so they're in this euphoric mood state, which is associated with this behavior disorganization. So that makes sense why they would be doing that, even if it doesn't make complete sense to me or it's not what I would do. Given their thoughts and beliefs, so we all think and analyze and understand the world differently, and because of that we're likely to do and handle situations differently. So this is a little bit of that putting yourself in their shoes and saying, okay, given the way that they think or understand the situation, what they're doing makes sense. So if you think about a lot of teenagers, we use this a lot when we're talking about self-harm with teenagers. A lot of parents come to us and say, I don't understand this at all. Like, I don't understand how this makes sense at all. But if their belief is that by doing that, they will get some kind of relief from what they're feeling, or that works or serves an important function, then you can understand why someone might do that. If they think no one will pay attention to them or notice them unless they do something extreme, then it makes sense why they would do that. So that's the thing that you would want to validate. You don't want to agree with the behavior, you don't want to say it's okay or encourage it, but just understand it as it making sense given the way this person thinks. Another possible explanation might be because of that emotional pain and lack of the person's coping skills. So if they don't really know other ways to cope with what they're feeling, then that might be a reason that they do the things that they do. And then we also want to emphasize when someone is being effective in the present moment, that doesn't mean that they are always going to be that way or they always have been that way. And so focusing on now that they're doing better, this makes sense. So what do you validate? So we validate facts. We say that if it's something that's a fact, yes, that's true. So if the person's upset with you because you yelled, yes, I did yell. That would be an example of validating the facts, even if you disagree with their response to that. So just validating the facts. Validating emotional pain and emotional dysregulation, that it's very difficult to live in extreme emotional states, and it's very difficult to figure out how to be effective. And so you can definitely validate the pain or the difficulty that that person might be having. The other thing is the task. If you're putting demands on someone or requests or asking them to do something, it might be very hard for that person to do it in their current state, even if it's not hard for you. And so something that we want to emphasize is really validating that, yeah, that task is hard. It is difficult. And I'm still going to ask you to do it anyway, but it is hard. You're right. It is hard. And then lastly, ultimate goals of that person. Validate that those make sense and that those are okay, and that, you know, for them, that's great. So you want to validate the things that are important to them. And also this sense of being out of control, that a lot of times people who have these disorders of severe emotion dysregulation feel like things are not a choice to them, or feel like things are out of control. And so you do want to validate that as well, that they are to some extent choices, but they don't feel that way at all. And they feel like you don't have any power, any control over them. And so really validating that, yeah, it must be really horrible to feel like you can't manage this or can't control this or don't know what to do to help yourself. So knowing how to validate that sense of being out of control. And so these are some of the other piece of building that empathy and building the compassion, is that we want to give family members education about causes of emotion dysregulation, so biology, how people develop problematic behaviors and continue to engage in them even when they have negative consequences from those, so understanding learning history and principles of learning, understanding emotional suffering, and understanding that there might really be a skill deficit where the person really does not know what else to do or how else to handle things. And then also education about how lack of interpersonal skills might be something that causes a lot of the conflict and a lot of the arguing and a lot of the suffering for family members around them, but how that is something that can be improved and can be worked upon amongst everyone. So ultimately, goal is more validation in general. So these are at our clinic services that we offer. So adult and adolescent DBT programs. We have full DBT programs at our clinic. We do meet for consultation team, and we do phone coaching. So we have all those major components of DBT. We also do individual cognitive behavioral therapy for mood and anxiety disorders. Family consultation, parent training. We also do biofeedback, which is slow breathing training to help regulate emotional states. There's a lot of research being done that shows that when people can learn to master slow breathing, that they can return to states of baseline from dysregulation more effectively, and they can also reduce their chances of being triggered in the first place, and so it's a very good skill to learn. And we also do full diagnostic assessments. So I'll open it up to questions at this point. Yeah?
Is an adolescent considered somebody less than 18 years of age?
Yeah, so we kind of in those categories where we have an adolescent who's 18 but in high school and still living at home, we might offer them the option to do either adolescent program or the adult skills group. So it's kind of up to on kind of an individual basis what might be effective for that family and for that person. But yeah, we've had adolescents in our adolescent group who turned 18 during the course of group. Yeah.
For clients looking at DBT versus CBT, what would you say are kind of like the main differences between those two types of therapy, and what do you normally recommend? I'm sure.
No, that's a great question. So the main differences are that DBT does integrate the mindfulness component. It's also a much more extensive treatment in terms of how many times per week you're meeting, the length of being in skills group, and the amount of phone coaching that person might utilize. And so typically we say that if someone comes to us with a diagnosis of just a mood disorder or an anxiety disorder, that doing a regular CBT protocol might be what is effective for them. But a lot of people, even with those, say, I've gone through regular cognitive behavioral therapy and I need more, and so they elect to do skills group. If someone comes to us and they're on the borderline personality disorder spectrum, we definitely recommend doing the full DBT program. So similarly, if someone has a lot of those skill deficits and they don't have a lot of coping skills, then the skills group might be a good idea for that. Yeah.
How do you train the families?
So we so we do something very unique, and not all clinics do it this way, but some do, where we set the parents up with a different therapist at the clinic than the one that their child sees for individual therapy. Because sometimes that relationship can get so murky with the parent, with the one therapist giving advice to the parent about, no, you need to really hold a boundary here, even though your child might be pushing it, or you need to apply a punishment. You can imagine that the teen might then feel like you've totally betrayed them or aren't on their side anymore. So to really let each person feel like they have their own support person, we divide it up that way, so parents get their own therapist to work with, and then the teens get a therapist to work with. And the parents typically meet with that therapist at least 4 to 5 sessions, and then that's kind of the mandatory, and then from there it's on a case-by-case basis. And then we hope that the parents will attend the adolescent sessions, and so the adolescent gets a chance to practice a lot of these communication skills and resolve arguments and problems, and that the adolescent will also attend parent sessions so that their therapist can give them feedback on how they're doing with responding to their teen.
Well, I was thinking of the percentage of success or failure rate on discharge from the hospital. You mentioned the interaction with the family. So I'm not thinking about just adolescents.
Oh yeah. So you mean with our adult clients, how much? So what happens a lot of the time is that an adult client will come to see us, and then somewhere in the course of treatment we find out that their family is playing a really big role in maybe keeping some of these problems around or not being as supportive as they can be. And so at that point we'll ask that person's permission if it's okay if their family is involved in treatment. At other times, parents come to us on their own when either their loved one isn't in therapy yet, or their family member is maybe thinking about starting therapy but not quite sure, and they'll get consultation from us separately. And so either way, it tends to work very differently depending on the specific case.
I wonder if you'd go back to the chart where you tried to describe differences between borderline personality.
Sure.
And then the list of things. I'm trying to understand some of this difference, even though the next, just where your chart was.
Yeah.
Right.
Yeah, sure. So, yeah.
If you could explain a
Sure.
little more to me. What is dysthemia?
Dysthymia. So dysthymia is a low mood state that is kind of a low-grade depression. It tends to be much more long in duration and much less severe than a depressive episode. And so what might happen is that people recovering from depression might go through periods of feeling dysthymic, or they're not completely back to baseline, but then they have kind of this low-grade depression, but it's not a severe depressive episode. And so that's a piece of it. So the main thing to get out of this is the distinction that borderline personality disorder does not include these periods of mania, whereas both bipolar 1, bipolar 2, and rapid cycling tend to include some period of euphoric mood, and so that's the big piece. And then also the time between these different mood states. So bipolar 1 and bipolar 2 are definitely associated with longer periods of time spent in depressive episodes and in euphoric mood than borderline personality disorder.
In your list, in the next list that comes on the next slide,
Yeah.
these seem also, as you pointed out, in many ways so much potential overlap as well with what we think of as bipolar, although these things having to do with abandonment or the unstable sense of self, these seem more typical of borderline. Is that right?
Yeah. So these are the criteria for borderline. But I would say unstable sense of self, that might be something that that does relate to bipolar disorder as well, but the abandonment criteria is something that's much more characteristic of borderline personality disorder.
Is,
Yeah.
When diagnosing adolescents, do you have any specific distinguished criteria that you use to give them a BPD diagnosis? Because I know like sometimes.
Yeah.
Teenage
You actually
timeline or.
You actually can diagnose borderline personality disorder in adolescence. So the exact wording from the DSM-4 is in early adulthood, people start showing these patterns. And with the teens that we do diagnose with that, they've typically been showing this pattern for quite a long period of time. And so I personally am very reluctant if someone's coming in its new behaviors and 1 or 2 episodes of feeling depressed and kind of recent development of problematic behavior, I'd be very reluctant to diagnose that with a personality disorder. But there are definitely teenagers that come to us that even though they're 16, have had really long histories of being in and out of hospitals, of self-harm behaviors, of suicide attempts, of depression, anxiety, and so those types of things. When you see a really long-standing history and a pattern, it might be appropriate to diagnose them that way because it might actually help them get to care that's most appropriate and best to treat what they're coming with.
that would be BPD that you would.
Yeah.
in those cases, I see.
Do you mind showing the previous slide, please?
Sure.
I couldn't scroll fast enough.
We all want as much of this as we
Yeah. So that purple line is just basically showing us the baseline mood state, and then the low dips are showing depression, and then you can see the length of time is written at the bottom, so months or weeks down to a day. So that's where those rapid fluctuations occur within the course of a day, whereas those fluctuations at the beginning of the graph are really occurring over the course of months to weeks.
So the BPD on the right doesn't experience mania,
No.
but they could if they are getting some kind of a stimulant type of antidepressant.
It's possible. I mean, I'd say that those affect every person differently, so it's very difficult to say. But typically, they tend to just kind of return to a more baseline state and be less reactive than really to ever have a very euphoric state. If they're used to really being in depression, it might feel very euphoric to them. If they're in a constant state of crisis and suddenly they're not, that might feel a lot different from what they're used to.
Could you say something more about, you referred to bipolar 1 and bipolar 2, and I assume partly it may have to do with this months, weeks, and weeks, days.
Mhm.
Could you say a little about the differences between them? Because my understanding was that mania can look very different in the two forms.
Sure. So bipolar 1 is basically the criteria from DSM-4, and we have this whole new version of DSM that's we're all reviewing and making our decisions about that came out last month. But from the DSM-4, basically the criteria for that you have to have had at least one manic episode, so a full manic episode, and that typically includes symptoms of grandiosity, so a lot of it, like inflated sense of self, thinking that you can do anything, impulsive behaviors, the elevated or euphoric mood, the risk-taking behaviors, things like overspending, over-gambling might be another one, those types of behaviors, very pressured, fast speech, feeling like your thoughts are coming in and out of your head and racing around. So that type of thing would constitute a manic episode. And so for bipolar 1, you have to have had at least one of those. And then for bipolar 2, it's actually hypomania and depression. So those are the two criteria to be diagnosed with bipolar 2, is that you have had at least one depressive episode, but you have periods of hypomania. So not the full manic episode, but some of the criteria for a manic episode, but not as much.
How would you describe the hypomania?
A less severe version of mania typically. And for each person, it might be a different constellation of those symptoms.
Like irritability?
Yeah, it might be a little bit more of that rather than the very, very euphoric mood. It's very different. And there are these rapid cycling versions of bipolar disorder where people go up and down from manic or hypomanic states down to more depressive states very, very quickly.
What suggestions would you have for family members who have somebody who would probably benefit from DBT but doesn't agree with that?
Well, there are a couple of things. Like, so if their family would like to make an attempt at changing this person's behavior, something that they can do is get some consultation from a therapist on strategies to encourage that type of thing. So usually families are involved in those clients' lives, and whether or not that person wants them there or not. And so there are usually ways of trying to convince them and making the environment such that it's more in their benefit to maybe try it out than to not. So we can give that kind of consultation. But also I would stick with those principles of staying away from the lecturing and this is something you should do, look at all this research saying it helps people. I know 10 people that have benefited from it. Maybe staying away from that and sticking with, so I know you're still having a hard time with this, and that you've gone to a couple different therapists now, you've tried a couple different things and nothing is really fitting. Is this something that might be an option? That might be a different way of approaching it, or linking it to long-term goals of that person and things that they're telling you that they really want. That might be something.
And will you do a consultation with the client themselves and talk to them about what is involved? Just because the whole dialectical behavioral therapy title is just so
Scary.
overwhelming.
Yeah.
It's scary,
Yeah.
So you'll sit down with them and discuss what it really is.
Yeah, and standard DBT has a very long orientation process before the person and the therapist actually both commit to working together on a long-term basis. So it's typically like 4 sessions of assessment, describing the treatment, orienting the person to the treatment, answering questions, and then at the end of those 4 sessions decide on a length of time that both the therapist and the client will commit to working together. And you can always reevaluate when it gets to that time whether or not you want to keep working together, but that might be another thing to bring up is, do you want to go and talk it over with someone for a couple sessions and see if this is right for you? And then at that point, you can make a more of a commitment to it. Yeah, so it actually is a really extensive orienting process.
When you get that far, what kind of insurance do you take?
Oh my goodness. So sometimes we have luck getting single case agreements for clients, and sometimes we don't. And so it's really, really individualized on the client that's coming to us, what their history has been. We're not on any insurance panels, so usually we have to work out an arrangement for that specific client. So our administrative person, Pin Brown, handles all of those requests. Yeah.
What if you don't have insurance?
We do accept private pay, yeah. Yeah, and we actually have licensed clinicians and training therapists, and so sometimes there's some flexibility on getting a lower rate to work with a training therapist. Yeah.
Hi, I have a friend who is considering this treatment for her daughter, who's, I think she's 14.
Mm-hmm.
And she's been looking into it. She understands that you have a program and that there's a program at Sharp Mesa.
Mm-hmm.
She wondered what the difference is. Do you know anything about that program? Or?
I do. I know a little bit. So I know that those are intensive outpatient programs that they have at the hospitals. Actually, one of our staff clinicians does work at Sharp as well, and so she's a really great person to contact. Her name is Amanda Gutierrez, and she could probably explain a lot more in detail what all the separate ones are. But ours are not day treatment programs, so instead of the person coming in and staying all day long and then going home at the end of the day, ours are much more into that structure of a 60 to 90 minute individual therapy session once a week and an hour-and-a-half long group once a week, and then maybe a parent or family session on top of that. So
It's just not as
yeah. Yeah.
I was thinking, how do you determine whether a client would do better in a group or one-on-one?
Well, we actually, both components are present in our program. So we actually do not have clients that come to us only for group without seeing any individual therapist, because the group is taught to, the purpose of it is to just teach the skills and deliver that in a format where a lot of people can learn them at the same time, so that then they can spend their individual therapy sessions really applying them to their individual situations and talking about that with their individual therapist. So we don't have people that only do DBT group. They're also having some type of individual therapy as well.
Thank you.
Yeah.
I'm sure you probably know about FFT or.
Yeah, family focused therapy.
How does the family component of DBT differ from FFT?
We actually use a lot of the same strategies, so around that gentle, validating style of communication, reducing overall conflict, having very clear expectations for expectations and behaviors that person is expected to do, chores. We do contracting and those types of strategies that are similar to FFT, and we do a lot of direct in the session coaching all the family members on interacting with each other, and also trying to do some of that compassion and empathy building for what the identified patient is experiencing, and giving psychoeducational pieces to help them better understand that. Yeah.
What is FFT?
Family-focused therapy is functional. Family-focused therapy, yeah, there's two FFTs. Family-focused therapy, which is a family cognitive behavioral therapy that's used for bipolar disorder. So we actually integrate a lot of the same strategies. The adolescent DBT, as it's written in the manual, is much more focused on explaining things from the borderline personality development theory. But if whatever the person comes to us with, we can tailor that for how that fits for them and their family. Yeah.
And so it sounds like it's a very individualized program.
Yeah. So we use the cognitive behavioral therapies. We do follow manuals, but at the same time, we make it very, very individualized to what that person needs, and are very flexible in some components. We want all the required pieces to be there, but want to be flexible to increasing whatever that is, or personalizing it to meet the needs of everyone. And especially recognizing that everyone's triggers for everything are very different, and so we pay a lot of attention to that and do a lot of individual work on triggers. So a lot of the cognitive behavioral strategies for that.
When you spoke of skills groups, you spoke about these didactic classrooms, and yet you made a very good argument that lectures might not be the best way to go about teaching people certain things. And so I'm wondering about it, particularly for adolescents, because I also have one. So how do you deal with adolescents in that situation? Because I'm not sure
Yeah.
that they
So lectures are usually ineffective for getting people to do things. So that piece of it, but for delivering information, it tends to be an effective way, and especially being in a very structured and organized format, it actually might help everything happen in a way that is much more feasible, so that the parent and the teen can learn the same information and come to the same place. With teenagers, sometimes it's definitely challenging because they have their own ideas about what they should or shouldn't be doing, whether they should or shouldn't be in treatment, but usually they work a lot with their individual therapist on helping figure out how going to group fits in for them and how learning the skills in group fits in for them. And we do have homework assignments that are assigned each week, and from being in the teaching 2 skills groups a week for the past few years, most clients come with their homework done every single week, and so.
Even the adolescents.
Even the adolescents, yeah.
Wait to do homework, Tim.
Yeah. Any other questions? Yeah.
Thank you very much.
Yeah.